Okay, this is the agenda. We are going to review the epidemiology, the pharmacology, the diagnosis, and the treatment of glucocorticoid-associated diabetes. So, for starting, this is an epidemiological study carried out in several hospitals in Spain, more than 100 hospitals. We collected data of patients admitted to internal medicine departments, more than 5,000 patients. Among them, 1,000 had diabetes or hyperglycemia, and among them, 18% were taking systemic glucocorticoids in the hospital. So this is a problem that we have already seen very often. Regarding the use of glucocorticoids in ambulatory patients, this is a big study carried in the UK, more than 20 years of observation, more than 4 million people, and among them, 7 out of 1,000 were taking corticosteroids at some moment in along these 20 years. The most usage is for respiratory tract infections, but also for inflammatory conditions, rheumatic conditions, also for inflammatory bowel disease, and less often for vasculitis. So, what are the risk factors for acquiring hyperglycemia related with glucocorticoids? Type 1 and type 2 diabetes also can be decompensated by glucocorticoids, and people who are at risk of having diabetes can have very high glucose values, especially if they have obesity, family history of type 2 diabetes, gestational diabetes, some ethnic minorities, and also women with polycystic ovarian syndrome. People with impaired fasting glucose or impaired glucose tolerance of abnormal levels of hemoglobin A1C between 5.7% to 6.4% are also at risk, and also patients who in the past have received glucocorticoids and have showed high glucose values. So, what are the mechanisms of action of glucocorticoids to produce hyperglycemia? Synthetic glucocorticoids, as you see, have to bind to a receptor in the cytoplasm of the cell, and the union of systemic glucocorticoids and receptor goes to the nucleus of the cell and produces modulation of DNA transcription. So at this level, there is a transactivation of anti-inflammatory proteins and transrepression of pro-inflammatory proteins, and that is the reason why the glucocorticoids are so potent anti-inflammatories. Glucocorticoids also produce a metabolic effect in the liver. They increase the production of hepatic glucose. In the pancreas, they impair beta cell function, and at muscle and adipose tissue, it produces resistance to insulin. We have to take into account the pharmacology of glucocorticoids. There are glucocorticoids of short action, like hydrocortisone. You can see here the duration of action is half hour, 8 hours. Prednisone and methylprednisolone are intermediate action glucocorticoids, and dexamethasone, betamethasone, and triamcinolone are long action glucocorticoids. This is very important to bear in mind because the control of glucose depends on the effect of the glucocorticoid along the day. So most of them produce increase of glucose postprandially, and we have to bear in mind to adapt the treatment. So, for monitoring guidance, we can say that people without pre-existing diabetes, we have to check the capillary glucose before lunch or before dinner in patients who receive glucocorticoids of intermediate action. like prednisone or methylprednisolone. In patients who are receiving long-acting glucocorticoids like dexamethasone, the effect is prolonged along the 24 hours, and we can check the glucose at every time in a day. So if capillary glucose is below 200, we can manage the glycemic effect probably with oral agents. But if the glucose level is above 200, we have to check more often the capillary glucose. For people with non-diabetes, we will need to check at least 4 times a day the glucose values preprandially. Okay, the glucose target should be a little bit less stringent than for people with diabetes, because the treatment is not going to be prolonged in the long term. So in general, it is admitted that glucose should be kept between 100 and 180 milligrams deciliter, and for a special population like patients with dementia, patients who are confused or frail older persons, people at risk of failing, or those with variable appetite intake, the control shouldn't be so strict, and just the target should be avoiding symptoms. So the level should be between 70 and 210. As I said before, if the glucose values are less than 200, we can use oral agents. The oral agents that have been more used are sulfonylureas, and among them gliclazide. Gliclazide is a short-action sulfonylurea that should be taken at breakfast or at lunch. Physiopathologically, DPP-4 inhibitors, glucosurics, or agonists of GLP-1 can manage the hyperglycemia caused by glucocorticoids, but these are experimental treatments. Metformin and pioglitazone are very slow-action drugs, and they are not recommended for treatment of glucocorticoid-induced diabetes. If the capillary glucose is above 200, we shouldn't use oral agents. We should move to insulin. And the best insulin to use for intermediate action glucocorticoids is insulin MPH, because insulin MPH given at morning matches perfectly the glycemia caused by glucocorticoids that appears usually in the evening and before night. For people who are non-diabetes, if the patient is taking 2 oral agents, we have to consider to add insulin MPH in the morning, or long-acting insulin if the patient is receiving dexamethasone. If the patient is using already bedtime MPH, we should move the MPH insulin to breakfast. And if the patient is taking multiple doses of insulin, we have to adjust according to the levels of glucose. Here you can see the action of different types of insulin, and you can see why insulin MPH is the perfect insulin for matching the hyperglycemia caused by intermediate action glucocorticoids. And insulin detamir and insulin glargine are perfectly for matching the hyperglycemia caused by dexamethasone. This algorithm summarizes all of these explanations. Here you can see for glucose values below 200, if the glucocorticoid is intermediate action, we can use oral agents. For long-acting intra-articular corticoids, we can use oral agents. For values of glucose above 200, we should use insulin. For long-acting glucocorticoids, insulin glargine or detamir. and for intermediate action glucocorticoids, if it is 1 dose in the morning, MPH insulin, and it is more than 2 daily doses, multiple doses of insulin. Now, how can we select the insulin dose? This is a matter of science and art, and this is a table which is quite useful, and the numbers for adjusting the insulin are taken from the dose of prednisone and the weight of the patient. So for prednisone 40 or more milligrams per day, we should divide the dose by 100 and multiply for the weight of the patient. For long-acting glucocorticoids like dexamethasone, the dose should be divided by 20 and multiplied by the kilograms of the patient. We can see here one case as example. This is a 60-year-old woman with obesity that is admitted to the hospital suffering from fever of unknown origin. Her main complaints were fever about 38 degrees daily in the last 3 weeks, headache and pain in the shoulders. Her past medical history was remarkable for hypertension and hypercholesterolemia, and the physical exam showed a small amplitude of temporal artery pulses and pain elicited with palpation of deltoid and supraspinous muscles. The neurological exam was unremarkable and her weight was 80 kilos. The blood test shows an anemia with an increase in the erythrocyte sedimentation rate, and the glucose is both in the level of increased fasting glucose. An ultrasound of the temporary artery showed a characteristic halo sign, and the biopsy confirmed the diagnosis of temporal cell arteritis. So this patient was monitored by capillary glucose 3 times daily, and she started with prednisone 60 milligrams per day, and these are the values of capillary glucose. As you can see, the glucose rise before lunch and before dinner, and the effect of the prednisone disappears at night. So we cannot use long-acting insulin because we could produce hypoglycemia at night. So according to the algorithm that I already explained to you, for this patient who weighs 80 kilos and is receiving more than 40 milligrams per day of prednisone, he received 32 units of insulin MPH at breakfast, and the following glucose levels in the day 3 and 4 were within the target that we wanted to achieve. Also, using this algorithm, we can tell the family doctor or the patient to reduce the dose of insulin according to the reduction of dose of prednisone along the months. So, in summary, glucocorticoid-induced diabetes is a common medical problem. The diagnosis and treatment of glucocorticoid-induced diabetes is often under-evaluated. Blood glucose monitoring should be carried out according to the pathophysiology, the type of glucocorticoid, the administration schedule, and the dosage in patients at risk. The treatment goals should be defined according to the type of patients, and the use of therapeutical algorithms can facilitate goal achievements. Many thanks for your attention.